Bismillahirrahmanirrahim. We start the third day of our conference and starting the cardiovascular risk in diabetes, how to assess and decrease it, by Professor Dr. Didac Mauricio from Spain.
After my talk on Thursday, there's not many people, but that's not the important thing. I guess that's the best people is here. So I'll try to stick to time, and I will give an overview of what is my bias on the issue of cardiovascular risk in diabetes. This is sorry. Can we have the slides? Great. So this is the outline of my talk, and this is just an overview. You know that cardiovascular disease is one of the main issues in affecting our patients. So first of all, I want to remind you again that this is not just type 2 diabetes, it's also type 1 diabetes. Our young patients with type 1 diabetes are still at largely increased risk of dying of cardiovascular disease in comparison with the background population. And this is just to show you, this is an Australian study, and if you look at the years of life lost in this population, you see that in red we have cardiovascular disease, okay? And this is the case both for men in the upper panel, but also for women. And you see here that the excess risk for women is also very high. And I just chose this recent meta-analysis showing which is the proportion of the cardiovascular risk affecting women with type 1 diabetes. This is a meta-analysis of different studies. And as you will see, most cardiovascular disease are much in excess in women in comparison with men with diabetes. So it seems that diabetes not only deletes the gender effect, but it's kind of reversing. So it seems that women with type 1 diabetes are even at much increased risk in comparison with men when you compare that to the background non-diabetic population. So we have to keep that in mind. And of course, the reasons for this increased risk is, on one side is hyperglycemia. This is a post-hoc analysis of the EDIC study, the follow-up of the DCCT cohort, and you'll see that the higher the HbA1c, the higher the risk of having cardiovascular events or dying from them. And it's not only glycemic control, but it's also mainly nephropathy. Nephropathy in type 1 diabetes, it's still one of the main causes of increased risk of cardiovascular disease. On one side, we have albuminuria, and then we have also, once the kidney function is impaired, your risk is much higher. When it comes to type 2 diabetes, you know that these patients are really at a very high risk, 2 to 4-fold, as we saw on Thursday. But as you see, most of the deaths are from cardiac origin, okay? Of course, we have also stroke and other cardiovascular events, but most of the patients are having events on the coronary territory. And when it comes to gender, this is a study of the Emerging Risk Factors collaboration that was published several years ago. And as you see, here again, female patients are at the hazard ratio for females is higher than for men. And we have to take into account that the younger you are, the higher is your risk, as you see here, okay? So It's not about elderly patients. It's mainly about younger patients. And you know that in many countries, type 2 diabetes is initiating at a younger age. And we have many factors. We won't go through all the factors that are associated with increased cardiovascular risk in type 2 diabetes. But of course, you know that they have higher hypertension rate and mainly dyslipidemia. Atherogenic dyslipidemia is very typical of our patients, but also other factors like obesity and other less known risk factors such as hypoglycemia. When it comes to smoking, we know that most of the populations of type 2 diabetes, they smoke less than the background population. And in the case of type 2 diabetes, we shouldn't forget that this line is when hyperglycemia is there. So this is the start of hyperglycemia, but you should be aware that the risk and cardiovascular disease starts even before that you have overt hyperglycemia in type 2 diabetes. So it's closely linked to other cardiovascular risk factors that occur much before also that hyperglycemia develops. Okay, so this is very important in terms of prediction. What about the assessment of cardiovascular disease in diabetes in general? We do not have very good tools to assess the risk in diabetes in general. And we have still the controversy of whether, as Dario mentioned, I think it was yesterday, that diabetes seemed to be, this was the first study by Hafner on the Finnish population, showing that it seemed in that study, with very few events, I must say, that patients with type 2 diabetes are at the same risk of having a coronary event as those patients without diabetes but already having a myocardial infarction. This has been explored in many studies after that study. This is one of the most cited studies in the literature. It's got thousands of citations, but there are many studies after that. And one of the problems with that study is that they didn't have a well-characterized type 2 diabetic population. And when it comes to, for example, the population in our region, this was published several years ago, you see that patients, these are patients with myocardial infarction, with no diabetes, and you see that here we have the type 2 diabetic patients, and they are not at the same risk when you take the overall population of our region. But the longer the disease duration, the closer you get to the risk of patients with myocardial infarction. And this is the background risk in this line. So you have to take into account many other factors apart from just being type 2 diabetic patient. And now we have this famous, I won't go through all the risk charts that I use in several countries. My preferred one is the one that the UK guys use. They have the Q risk chart, which was developed based on millions of subjects, and they have into account many other factors like ethnicity, diabetes, and so on. But this is not the case of many of the charts that we have available in our countries. Do you have a chart specific for Egypt? Do you? No? In Spain, we have a kind of adaptation of the Framingham, but we should use the score as recommended in the European guidelines. But these charts have many limitations, at least in patients with diabetes. And this was already published a couple of years ago, trying to see whether these risk charts performed well in patients with diabetes. And as you see, most of them do not perform well. So they lack external validation, they have very moderate discrimination, and they do not have a proper calibration for the local populations. So in the end, what we have when we go to the guidelines is, okay, the guidelines, this is the European one, and it says either you are at very high risk if you have diabetes, or you have high risk when you have diabetes, except probably for those patients here that are young, mainly type 1 diabetic patients that do not have other cardiovascular risk factors. These patients probably are at moderate, and even some of them at low risk. But most of our patients are at either high risk or very high risk for cardiovascular disease. And this is also the case for the American guidelines. And as you know, taking into account the age, only those, and this coincides with the European guidelines, only those that are younger with no other cardiovascular risk factors are really at a lower risk. Otherwise, these patients should be handled in a way that you should consider them at being at real high risk. But I guess that we shouldn't go on for many years in the 21st century just talking about potential risk, just calculating, because most of the myocardial infarctions take place in populations that are at intermediate risk. And that means that many patients have myocardial infarctions and are not well predicted in cardiovascular charts. So I guess that the future will bring new ways of addressing whether you have atherosclerotic disease or not, either with biomarkers or combining them with, for example, imaging. You know that we can look into our arteries without being aggressive, just with ultrasound. So probably the future will bring what is now known as precision medicine. Okay, so the aggressiveness of the treatment will come on whether you have already some plaques on your vascular territories. We talked about lipid lowering on Thursday, so I won't go into that. And yesterday, Leszek talked about blood pressure lowering extensively, so I won't go into, you know that these two have a great impact in terms of prevention of cardiovascular risk in diabetes. What about lifestyle measures? We have one very representative study. This is the Look Ahead study. These patients were, some of them had pre-diabetes, but most of them had type 2 diabetes. And as you see, the trial took 10 years, and they nicely show that those patients that were treated with intensive lifestyle measures improve in terms of both weight and waist circumference. Both are measures of adiposity. They had a better physical fitness, okay, and they showed an initial lowering of a decrease of HbA1c, but then they almost had the same HbA1c at the end of the follow-up after 10 years. But in terms of cardiovascular outcomes, they couldn't show that intensive lifestyle management was different from the usual care. Does that mean that lifestyle measures do not work? I don't think so. And we have, and you know that everyone says that lifestyle should be there forever once you have diabetes. And if this is the case, probably we do not pay much attention to this. We tend to forget once we have the initial measures that we should insist on that. But we have a sub-analysis of this trial showing in this slide. This was published last year. And you see that those patients in which you have a real impact in terms of weight lowering, you get prevention of cardiovascular disease. You get around 20% prevention of cardiovascular disease. So this is very illustrative that lifestyle measures should be there. What about lowering glycemia and its impact on cardiovascular risk? And we have the landmark study in type 1 diabetes. That's the DCCT study, with which you may be very well acquainted. If you remember, these patients were treated and there was a 2% difference in the intensively and usual care at that time. And the study had a mean duration of 7 years, and once the study finished, both arms of patients were treated intensively. And you see the HbA1c, and they decided to follow up that cohort with the EDIC study, okay? And we have many data of this, and they have followed the patients up to 30 years, okay? The trial finished at 7 years. As you see here, there were no differences in terms of cardiovascular outcomes. It was too short time to see any difference. But if you see here, the curves separated, so those patients that were treated for 7 years in terms of glycemia intensively, they had a better outcome in terms of cardiovascular endpoints, as you see here. So this was the first study. It was not the UK-PDS, this was the first study. You heard yesterday Andrew Bolton talking about glycemic legacy. But these guys, the name they give to this phenomenon is metabolic memory. So that means that your arteries remember, they have a memory and remember the exposure they had to high glycemia, okay? And if you go to the meta-analysis, if you meta-analyze all the available studies in type 1 diabetes, you see that you get prevention of myocardial infarction, but you cannot see a prevention in terms of cardiovascular disease. And then we have the UK-PDS, and as you remember, in '98, the final results of the study after many years were issued, and you see here that they were not able to show a difference in terms of myocardial infarction when you compare the intensively treated patients. Actually, they were not so intensively treated, but it was how they were managed at that time. But then several trials were planned at that time, saying, okay, we're going to treat patients really intensively. And we have 3 landmark studies that were published almost in the same year, 2008, and beginning of 2009. This was the ACCORD, the ADVANCE, and the Veterans trial. And you know that the ACCORD trial was primarily early stopped because of the increased mortality in the intensive arm, okay? And the other 2 studies could not show a difference when you really intensively treat type 2 diabetic patients. But in the UK-PDS, as Andrew Bolton mentioned yesterday, you see that they also follow up their cohort, and they could see that those patients that were treated intensively, in the end, after less than 10 years of follow-up, they could see a difference in terms of myocardial infarction and total mortality. So it seems that, yes, metabolic memory or glycemic legacy, it's there. But if you go to the literature, you may find around 14, 15 systematic reviews or meta-analysis. I just took this 4 meta-analysis, and they all show that in terms of glycemic control in type 2 diabetes, if you intensively treat your patients, you get a kind of reduction around 15% with essentially no other major effects. So to summarize this, if you treat patients with type 2 intensively, you get a reduction of non-fatal myocardial infarction with no effects in terms of mortality, and no effect on other vascular territories so far as we know, an increased risk of severe hypoglycemia. But something happened in 2008, and we kind of have a new era in cardiovascular outcome studies in diabetes, because after I think that was not a successful meta-analysis, the one by Nissen the year before that. The FDA decided that any new diabetes drug should demonstrate cardiovascular safety. And this is just to illustrate that these are thousands of patients included in major clinical trials after 2008. And you see we might now be around close to 200,000 patients included in cardiovascular outcome trials. But these are not really glycemic control trials, as you will see. And this is how the party goes on. We are now in 2018, and we already have the results of several of these studies. I guess that Dario mentioned that yesterday. I was not here. And I'll just mention a couple of them, because this is the EMPERACT study. This was the first one, and we were really surprised about the results. They clearly showed prevention in terms of the primary main outcome that these studies have, and also, and very importantly, in terms of cardiovascular death. So that started to make a difference. And then we had the LEADER trial, in which this was not a large effect, but it has an impact in terms of reduction, in terms of a 13% reduction in the primary outcome and also in cardiovascular death. So the guidelines, I just took the example of the guidelines saying, okay, if you have cardiovascular disease, you may consider to use one of these drugs already. And then this year, we had the results of the GAMBA study. So it seems that SGLT2 inhibitors are there, will stay here for many, many, many years, because they have an effect. It seems that the effect may not be just in diabetes, but also in other populations. So what I would just consider some issues. The individual effect of hypoglycemic therapies is now very relevant, as you have seen. But not always the hypotheses that are generated by observational study are confirmed in randomized trials. And I took the example of hypertension. If you look at the observational study and you see this nice relationship between the diastolic blood pressure and coronary heart disease, this is nice relationship. But if you go to the trials and see the reduction in terms of blood pressure, does not bring your risk back to the initial one, okay? So it might be the case that in terms of glycemic control, we just have a low impact of intensive glycemic control in this part of the therapy on cardiovascular outcome. And we have to consider that all these trials are performed in patients that have a long disease duration. And we talked about the metabolic memory. So this is the example that Stefano made some years ago. If you have a population that has been under a long-term hyperglycemia with clear hyperglycemia, the longer and the higher is your hyperglycemia, the less you will have the impact of intensive control in terms of vascular outcomes. And as you see here, if you bring intensive control to these patients, this is too late, okay? So you have to intervene in the very beginning. And also we have to consider that nowadays, in many patients are in the flattest part of the relationship between hyperglycemia and risk. And I took the example of microvascular complications in the DCC trial. Of course, if you lower your HbA1c from 12 to, for example, 9, your risk is really very much reduced. But if you reduce your HbA1c from, for example, 8 to 6.5, the risk reduction may be marginal. So we have to take that into account also for cardiovascular disease. And now this is my preferred study which other cardiovascular? This study is a small study, a long study. For me, it's my favorite trial. This is the STENO2 trial. And the results of that trial, with only 80 patients in each arm, really changed our practice, okay? And they nicely showed that you have to intervene in all the factors that contribute to cardiovascular disease. This study was performed in patients with microalbuminuria, and they nicely showed that you can prevent cardiovascular disease and cardiovascular mortality. And this is a paper that they published last year with the follow-up after the 8 years that the study took place. And you see that still patients that were treated intensively in all the factors have a reduced cardiovascular morbidity and mortality. And this is the case for most of the outcomes, okay? And if you analyze in this very high-risk population, which is the contribution of each part, you see that lipids and hypertension, but mainly lipids, have a really very high impact in terms of cardiovascular prevention in high-risk type 2 diabetic patients. And just a word on antiplatelets. You know that usually we do not use antiplatelet therapy as primary prevention in type 2 because we have at least 2 large trials showing that it seems not to work. But I took the ADA recommendation saying, okay, you should consider, of course, if you have cardiovascular disease already, you should use that, and then you should consider, you have to individualize each patient, and if the patient is really at very high cardiovascular risk, you could consider using aspirin in the prevention. And of course, never forget smoking. We could have a special workshop for that. So which are my conclusions? In patients with diabetes, the risk is at least twice as the background population, and this is especially so in women. And do not forget that, because we have data of our own population that we treat less intensively women with cardiovascular disease and diabetes. Type 2 diabetes is characterized not only by hyperglycemia, but by an aggregate of other cardiovascular risk factors that are closely associated with cardiovascular disease. And glycemic control is effective, especially if you intervene very early. So the earlier, the better. Treatment of dyslipidemia and hypertension have a greater impact, at least in type 2 diabetes, but also in type 1. Intensive glycemic control reduces the risk of myocardial infarction, but not clearly has an effect so far as we know with current trials in other outcomes. And the multifactorial approach seems the best strategy that we should use. So this is really difficult. It's not easy. You have to adapt each patient to his or her treatments. And now cardiovascular disease status should be considered in decisions on hypoglycemic therapy. And I just took this recent review of Angelo Avogado, one of our friends coming to some of the courses. And this is a nice review because he considers the situation in terms of risk or established cardiovascular disease and which is the preferred therapy or which therapies you should avoid in a given patient. So the preventative effect of glycemic control would happen in probably early stages of type 2 diabetes, and probably that's the same for type 1 diabetes, so that we have what is called the metabolic memory on our cardiovascular system. And we should investigate still the best strategies. This is a very recent paper from the Swedish cohort, both in type 2 and type 1 diabetes. This is a register of the whole country, and it gives us the information of the blue lines are the type 1 diabetic patients here, and the red lines are the background population, and you see there's a big difference still. Still we have this, the last year in the follow-up is 2014, and we have improved, but we are far from reaching the optimal way of giving patients a more quality and more quantity of life. This is type 2 diabetes, and as you see, for example, we have still many differences. So thank you very much, I guess.
Thank you, Dr. Didac, for this elegant discussion and the talk. Thank you.
Okay.
As usual, you are very elegant. As usual, you are very concise to the time and very elegant. Are all the people of Spain and Barcelona like you? Exactly on time?
Yeah, thank you.
You started before we came. Thank you for your very elegant. We will talk.
Do we have questions? Or?
Okay, no problem.
Yeah.
Just one question. Okay. No problem.
Professor, I'd like to ask in the light of the results of the CANTOS and the REVEAL trials, do you think, Professor, that canakinumab and citrabib shall add on therapy for second prevention, especially for diabetic patient with residual cardiovascular risk?
I couldn't.
CANTOS trials REVEAL.
So I didn't know. Yeah.
Residual cardiovascular risk. Patient with residual cardiovascular risk in the light of the CANTOS and REVEAL result.
I mean, you
Cardiovascular risk.
The recently published.
I didn't show the results. You were talking about Canvas?
CANTOS REVEAL.
Yeah. I didn't show the results because this talk, you know that everyone mentions in their talks this study, so I try to keep away from those studies. But the Canvas study showed nicely that you can prevent cardiovascular disease also with canagliflozin. They had a problem with peripheral, with amputations, and this is a big question mark, not only for canagliflozin, but also for the group. We will see, because the EMPA-REG study did not have an adjudicated outcome in terms of amputation, so we have to wait for the CLARE study. But my conclusion on those studies is that for the time being, SGLT2 inhibitors should have a class effect in terms of cardiovascular prevention. They have a major impact in heart failure. I didn't talk about heart failure, but that's an increasingly important issue in both type 1 and type 2 diabetes. There are studies showing that they are both at increased risk of heart failure. So this class of drugs have a major impact on that. And we should be aware of the effects of canagliflozin. So I would stay away from using those drugs in those patients at high risk of amputation. Yeah, thank you.
Now I want to welcome the next speaker, Professor Evgenya Patrakeeva. Her presentation is entitled Diabetes in Adolescents. Please.
Dear friends, good morning. First of all, I would like to thank you for your active participation during yesterday's workshop. Thank you for your comments, for your cases, for your questions. It was really a pleasure to be with you during the workshop, and thank you for you to be here. And today my talk will be about very difficult and interesting topic. We will spend next 30 minutes talking about diabetes in adolescents. And I want to start with the words of Jean-Philippe Passal, who said that sufficient doctors looks to the world through the patient's glasses. And I also want to add something. Sometimes we even need to look to the world by the patient's way of thinking. And it's true for adolescents with diabetes. Why? Because sometimes teenagers think like that, or even like that. Of course, it's a joke, but a joke with a huge part of truth. And because of these pictures, I just want to ask you to raise your hand if you even once in your life had some problem in communication with adolescents. Do you have any problems? Yes, and I have an answer why. Because there are some key development tasks to adolescents. Of course, it's separating from parents first. And second, they need to become an individual able to independently form opinions, ideas, goals. That's why adolescents are interested in becoming more independent from their parents, and independence in diabetes care is part of that. And we need to keep it in our minds. We will talk about something about epidemiology, diagnosis, treatment, barriers to treatment, healthcare organization and transition process, and psychological support for adolescents. Let's start from epidemiology. Of course, everybody knows that there are a lot of children with diabetes now all over the world. Even my country is here. As you can see, we have the 6th place for Russian Federation. And there are some key messages about epidemiology for this period of time for our patients. Of course, in most Western countries, type 1 diabetes accounts for over 90% of childhood and adolescent diabetes. But less than half of individuals with type 1 diabetes are diagnosed before the age of 15 years. Also, type 2 diabetes is a problem now for this category of people with diabetes. Of course, we have a variety greatly between different countries, within countries, and between different ethnic populations. And rise in incidence has been noted in many countries. For example, in my country, we have a great increase under the age of 5 years. There are some data. I just want to show you that not only in Egypt we have increase in population of children and adolescents with type 1 diabetes. Even in my country, it's true, because there are some differences between years here and here. And we need to remember that the problem of diabetes, as we discussed yesterday during the workshop, it's not a problem with type 1, only with type 1 diabetes. Of course, it can be type 2 diabetes and even monogenic diabetes. There are some very clear diagnostic algorithms for understanding what type of diabetes has the child. Of course, we need to remember about age of starting diabetes, any symptoms, and that's why we will see that it's probable type 1 diabetes, on probable type 2 diabetes, or even MODY. Why is the type 2 diabetes is a great problem now? Of course, because we have a lot of new diagnosed type 2 diabetes in adolescents. They have some relatives with type 2 diabetes, of course, and 21% of all adolescents with severe degree of obesity, irrespective to ethnicity, were found to have IGT or prediabetes. And there are a lot of ethnic differences here. Why it's so necessary to remember about it? Because these adolescents have more rapid progression against adults. They have poor microvascular outcome, more rapid against children and adolescents with type 1 diabetes. They have secondary obesity-related complications, hypertension, non-alcoholic fatty liver disease, metabolic syndrome, and cardiovascular outcomes, even in this age. Of course, we have some typical clinical characteristics for type 1 diabetes, type 2 diabetes, monogenic diabetes, and we also start to discuss this yesterday. And you don't need only to remember about age of onset, but sometimes we have some problems with this classification. We need to remember about clinical presentation, genetic, probability of ketosis, glycemia, obesity, and about some signs and symptoms also. What do we need to evaluate in these children? We need to remember about classification of diabetes. We need to review symptoms and need to think about initial treatment. We need to remember about diabetes history, hospitalization, occurrence of acute complication for this category of people. We need to ask about family history, of course, current treatment approaches, assessment of patients. For our category, when we are talking about adolescents, it's also we need to ask something about family, psychological and educational needs, and we need to evaluate diabetes complication or other acute conditions. Of course, we need to do something with follow-up plans for our adolescents. If we will look at like assessment through the lifespan, of course there are some issues for infants and preschool children, for school-age children also, and for adolescents the main thing is identifying the need for counseling services. Of course, we need to remember about targets, and as is written here, for all children, the target is less than 7.5% for HbA1c. And also, it's possible to have the lower target for treatment in case if we can achieve it without any hypoglycemia. And it's true also for adolescents. Is it a real target for this category of age? Not really, because if you look here, you can see that the period of time for adolescents is we have some problems with target. Even here, if we will divide this category for some group ages of group, that only 17% or even 14% of our adolescents have the target level of HbA1c. How do you think? Is it true only for HbA1c level, or maybe we have something more in problems with adolescents with diabetes? Of course, we have some more problems. Here we have a huge rate of DKA in adolescents, and also an increasing level of severe hypoglycemia in this age, and it's very important. What can we do with that? From the point of view of organizational of healthcare system, of course we can do something. We can coordinate the care. We can manage every case, and we need to do something with behavioral or family system, some therapy for that. What does it mean? Of course, we need to attend clinical appointments for our patients, ensure transportation for clinics sometimes, adequate medical supplies, liaison between medical team and family. Sometimes we need care navigator for our adolescents. We need family-based problem-solving care system, communication skill training for parents of adolescents or for us as healthcare providers. We need manage of family conflict if the persons have it, establish proper supervision. And of course, we must work with schools, maybe have some assistance for job for adolescents, assistance with domestic violence issue, because it's true for adolescents sometimes, insecure housing or other resources for the family. It's also our responsibility as doctors. Why it's so hard to work with adolescents? Again, because there are some attitudes of adolescents and emerging adults. It's autonomy. They want to be as different from current adults as possible. And it's affiliation, because they want to be admired by peers. Also, there are some data that confirm the story that adolescent-parent conflict is associated with worse adherence to treatment, worse metabolic control, worse quality of life, and increased depressive symptoms. Is it important? How do you think? Yes, I agree, it's very important. And what are the barriers to success in working with adolescents with diabetes? Sometimes it's burnout, inadequate motivation and support from family, from healthcare providers, fear and actual hypoglycemia, sometimes weight gain, and need for frequent blood glucose monitoring. In addition, in adolescents we have comorbidities, endocrine changes leading to increased insulin resistance, erratic meal and exercise pattern, poor adherence to treatment with omission of insulin, eating disorders, and hazardous and risk-taking behavior. Let's talk about it for some minutes. First, about comorbidity, and I want to stress that depression in diabetes is recognized comorbid factor leading to the poor glycemic control, and our adolescents have high risk for eating disorders and substance misuse. And again, there are some psychological issues in working with adolescents with diabetes. That's why we really need psychologists in diabetes team. That's why ESPAD recommended routine annual screening for depression of all young patients with type 1 diabetes above the age of 10 years. Don't forget about it. If we will talk about omission of insulin, it's real true, especially for girls with type 1 diabetes, because they want to keep their weight. And of course, omission of insulin leads to glucose continues to circulate in the blood, glucosuria, body forced to obtain energy from fat and muscle stores, and they have rapid weight loss. Is an often situation? Yes, and data support it. There are also problems with intentional insulin omission and also a term like diabulimia. It can be an appropriate compulsory feature of bulimia nervosa or component of other specified eating disorder. Is it dangerous? Yes, and dangerous, because there are some short-term complications of it with insulin omission association with recurrent events of DKA, even with recurrent episodes of severe hypoglycemia, but also with long-term complication with poor metabolic control and higher hospitalization rate. Also, there are some combination about eating disorders and chronic complications of diabetes, as you can see here. It's true not only for retinopathy, but also for nephropathy if food problems in teenagers with diabetes. And it's also a problem which correlates to mortality level. So the problem is huge, and we need to remember about it every time when we are talking with teenagers with type 1 diabetes. So there are some care issues: education, glycemic target, insulin therapy, glucose monitoring, nutrition, hypoglycemia, DKA, but also issues with alcohol, smoking, drugs, sexual health, driving, psychology, comorbidities, complications, and transition to adult clinic. Let's start from education. And there are some very important issues need for teenagers with diabetes. We need to develop a trusting relationship, clarify priorities and set achievable targets, encouraging the adolescent to participate in making decisions about diabetes management, offering a variety of education opportunity. Now we have social networks, text messages, peer involvement, group learning, and so on and so forth, helping patients in their changing role from full responsibility toward a gradual transition to cooperative care. And of course, also we need to remember about schools, camps, psychology, substance use, contraception, career choices, and driving. What we can to say about diabetes in school? As a large portions of child's days spent at school, close communication with and the cooperation of school or daycare personnel are essential for us as doctors. Team of trained school staff who volunteer to undergo diabetes education. We need to use it. And also we need to use written medical plan or emergency plan by parents and or doctors to help our children be safe in school. SAP therapy, sensor augmented pump therapy, or flash monitoring system also can be helpful. So we need just do it, not only think or discuss, we can change something in this situation about diabetes in school. What I mean, talking about different approach to therapeutic education, of course it's flexible regimen, maybe some social clubs, web resources, mobile applications, and everything with temporal parentectomy. We do it in this way. In St. Petersburg, we have just a meeting every last Saturday, every month with patients with type 1 diabetes. And I want to say that we're trying to collect information about teenagers. And true is that 80% of all our patients during such meetings are teenagers. So the teenagers like to communicate with each other and also with doctor in such atmosphere. Also, we need to remember that HbA1c and motor health crash is an often situation in teenagers. And of course, if the HbA1c level is less than 6.9, it's associated with 3 times higher risk of accident comparing to more higher HbA1c level. And we have some requirement for safe driving for teenagers with diabetes. They need to check blood glucose or inspect the CGM display. Cars should be stopped with plenty accessible treatment for hypoglycemia. And anytime there are long distance driving, a plan should be a place for routine checking or blood glucose. Alcohol. Is it a problem for teenagers? Sometimes yes. And first of all, we need to give them information about effects of alcohol, about risk of late hypoglycemia, about fact that hypoglycemia may be confused with intoxication, and they need to inform their friends. They need to remember to eat carbs, maintain good hydration, and check blood glucose before going to sleep. Smoking. What they need to know about it. We need to inform our patients on increased risk of cardiovascular complications. We need to help them to quit and recognize that cannabis may alter eating habits and may reduce motivation to maintain good metabolic control. Illicit drugs may alter brain function, increase the risk of mistakes and mishaps with diabetes management. It's true. And there are some data from Australia that tell us that 77% of adolescents with diabetes tried drugs at least once. They use several types of drugs. Consumers were similar age or non-consumers, and drug users had higher HbA1c versus non-users. So just keep in your minds. About sexual health, the main thing is that we need to be very, very, very hard in talking about pre-pregnancy counseling and about contraception. There are a lot of options for our teenager, also bare methods, oral contraceptives, morning after hormone pill. Of course, we also have long-acting reversible contraception things, but without any protection against STIs, so it's a disadvantage. How can we improve glycemic control? Of course, through education, exercise strategy, bedtime strategy, check overnight, blood glucose awareness training, counsel about effects of alcohol, drugs, smoking, and so on and so forth. But what are the main treatment approaches? Of course, as we are talking about type 1 diabetes, if it's insulin treatment, and there are some normal levels of subcutaneous insulin administration at diagnosis for type 1 use. But also we need to remember that during puberty, requirements may rise substantially above 1.2 units per kilogram per day, and even up to 2 units per kilogram per day, so high enough dosage of insulin. Also, we need to remember that in this age, priorities in treatment are making diabetes regimen flexible, learning benefits of optimal control. In early adolescence, priorities are increasing insulin requirements, more difficult control, it's true, weight and body concerns, because it's important for our patients. And later adolescence, it's transition and integrating diabetes into new lifestyle. Can we use pumps in teenagers? Yes, of course, because it was written even in guidelines from pediatric societies. Why? Because there are some benefits for our teenagers: precise insulin delivery, various bolus types, temporary basals raised, different basal patterns, and significantly less infusion set changes than in MDI. But also, we need to ask some questions before we start CSI therapy, and they're following. What are the reasons for waiting for start pump therapy? What will be better about being on a pump than doing injection for you, dear teenager? What might be worse about being on a pump than doing injections? Where will you keep the pump on your body? Because it's important for teenagers. Do you know others with a pump? It's also important for teenagers. Is there a sport or activity that you think will be easier with a pump? why it's so important? Because body image concerns about wearing a device, it's a huge problem for teenagers with diabetes. It's also important to remember the concern about losing privacy because pump is more out than the MDI. So for our teenagers, it's not only the way to have a better treatment, and it's also a way to have a better psychological support. Is sensor useful for this category of patients? Yes, because for all group, even for teenagers, in this study, CGM was associated with decreased HbA1c levels and time spent in hypoglycemia. And of course, we need to remember about the importance of transition from pediatric to adult care. And I want to stress that we need to start to prepare for transition at least 1 year before the transition to adult health care. What is the age in Egypt for transition from children's service to adult? 18. 18? 14. Oh, even less. Because in Russia we have huge discussions about the age. We have 18 years old. I think that it's too early. 14 is also like, no? 18? 18 by law. By law. Okay. What is the situation in Spain? What is the age for transition? 18. So the same. And I think sometimes it's really too early because our patients, still children till the age, sometimes even 25. And both pediatricians and adult healthcare providers through the system provide support and links to resources for the teen and emerging adults. It's true. I want to stress also that transition is a process, not an event. And of course, there are some milestones for our patients, for our teenagers. They need to complete school, leave home, become financially independent, getting married, having a child, and so on and so forth. And on the top, manage their disease. So it's not easy task. There are some data about transition, a lot of data, and one of them tell us the high rates in clinic attendance 2 years post-transfer were seen in districts where young people had the opportunity to meet the adult diabetes consultant prior to transfer. So we need to work with suggestions that we need to work together with pediatricians. There are some recommendations for transition. Of course, it's person-centered and needs-focused. Include lifestyle, psychological, educational, vocational, medical issues. We need to involve young person and family into planning of transition. It's very important to have opportunity for young people to make appointments and consultation without parents, sometimes temporal parentectomy, as I told you before. Let young person gain independence and take responsibility for their own healthcare choices. Where to start from? Of course, we don't need teach and tell, because usually doctors tell the patient what she needs to know and do. Doctors usually diagnose, determine the treatment, measure the outcomes. Better results with teenagers will be if we will collaborate and empower. In a situation when doctor and patient have a role making in decision, doctor should describe, understand the disease, give an explanation for the patient about prediction and choice. We also need to listen to our patient, because when the patient feels that you listen to him adequately, he will be more open to your suggestion. It's true. Of course, we need to have some concerns about motivational communications, about avoiding arguing, non-judgmental curiosity, and expressing empathy, because it's very important for our patient. We do not only think about avoidance of hypoglycemia, target glucose level, absence of chronic complications. We need to think about quality of life for our patients, even for teenagers with diabetes. That's why, just to summarize, I want to discuss with you some approaches to overcome barriers in adolescence. Right diagnosis is important. So it's not only type 1 diabetes always, it can be type 2 diabetes or MODI. Family support and psychological issues matter. Flexibility in dietary and management plans matter. Extended outreach and support are very important. And we need to provide realistic expectations and achievable goals for our teenagers with diabetes. And of course, we need to help them during transition. Thank you for your attention, and thank my patients for inspiration for this talk. And again, I want to tell you that if you need some slides or some data from presentation, you just can write me by email. And I ask you to follow the official EASD account on Facebook and Twitter. And if you have any comments or questions or pictures or something, you just can use the hashtag EASD Postgraduate Egypt just to let us know what was interesting for you. Thank you for your attention.
It's really lovely how all of you stick exactly to the time. Thank you for your very elegant talk. We would like to invite Professor Boris, and then after this we will open the discussion, if you please. Come to the first row.
Mr. Chairman, ladies and gentlemen, first of all, I would like to thank the organizing committee. I would like to thank European Association for the Study of Diabetes for such a great and exciting opportunity for me to be part of the faculty in this course. And it's really honor and pleasure for me to arrive to Cairo and to be able to participate in the course. And today I am going to talk about a quite unusual association, unusual in the mind of many physicians and in the minds of many patients, but not so unusual actually. I will try to persuade it about this. I mean as an association between depression and diabetes. And the title of my talk, as you can see, Depression and Diabetes and New Chronic Complications. However, my task is, and I will try to do my best, to show that this is really not new complications. It's quite old complications, but unfortunately complications we didn't and we still don't pay enough attention to. And actually now we can say that both depression and type 2 diabetes are two leading causes, global causes for morbidity and mortality. And we all know that we are facing now the epidemic of diabetes, especially type 2 diabetes. We know how many people, how many hundreds of millions of patients with diabetes we have right now in the entire world. But depression is also very prevalent. And you can see, for instance, this data that the type 2 diabetes affects around 9% of population, and depression affects 5% of the world population in any given year. So it means that we are dealing with hundreds of millions of subjects with diabetes and with depression. And just recently, the mental health, let's put it this general way, and depression and cognitive impairments and psychosocial disorders and dementia are really paid attention in many guidelines. And for instance, you can see here the extract from American Diabetes Association Annual Standard of Care, published at the beginning of this year. And you can see that amongst the common comorbidities, cognitive impairments, dementia, psychosocial disorders are outlined here in these guidelines. So I mentioned already that I doubt that the association between diabetes and depression is really very new. And probably you can agree with me, because as long ago as 17th century, the famous British philosopher and physiologist Thomas Willis suggested that diabetes is caused by sadness or long sorrow. Well, of course, now we don't probably think that diabetes is caused by sadness or long sorrow, but this association was noticed you see, many centuries ago. And now, once again, we try to address this issue in our regular clinical practice. So the question is, how often we face the patients who have both depression and diabetes? And the answer is that we face these patients very, and probably one more time, very often. Because you can see the results of meta-analysis for 39 studies, and you can see that elevation of depressive symptoms were found in this case in approximately 1/3 of patients with diabetes. But probably what is more alarming, what is more disturbing, what is more important, that approximately each 9th of patients with diabetes had major depression. So it's really, we are talking about 11% out of those millions of patients with diabetes. And of course, it's very important. But that meta-analysis, of course, was not the only one. We have now a lot of data. You can see the huge study which included 250,000 participants from 60 countries, and the prevalence of depression in the study was around 10%. In other studies, the prevalence was even higher, and was around 25–30%. So now we are participating in the large multinational consortium addressing the prevalence of depression and diabetes in many different countries and many different regions. And preliminary data suggests that the prevalence of depression in patients with diabetes again is around 24–25%. So it's really very high number of patients with depression, and again it's a very important problem, keeping in mind the high number of diabetic patients itself. If diabetes and depression coexist, this association has really very significant and very negative impact on the overall health of the subjects. You can see here the impact of the I don't know whether it works or no. We can see here the impact of diabetes and depression on the health, and this impact was much worse compared to impact of, let's say, diabetes taken alone, or depression taken alone, or some other chronic disease. It's necessary to point out that the link, the association between diabetes and depression is so-called bidirectional association. What does this mean? It means that diabetes increases the risk of depression, and depression increases the risk of diabetes. And you can see on the slides the meta-analysis of 42 studies, and it was shown that it was a significantly increased risk of depression in patients with diabetes, but again, it was increase of diabetes risk in patients with depression. And this is a more recent study. I apologize for quite busy slide, but you can see here, for instance, I don't know whether pointer works or not. Just mouse. Okay, thank you. You can see here. Sorry. Yeah. No. Okay. Well, so you can see here the comparison of the risk of depression between patients with diabetes and control group, and you see in all age group it was significantly increased risk of depression. And in this table you can see the comparison of the risk of diabetes between patients with depression and patients without depression. And once again you can see significantly increased risk of diabetes again in all age group. So again, so it's bi-directional relationship. Moreover, if depression is developed in patients with diabetes, it is associated with increased risk of poor glycemic control, increased risk of development of diabetic complications, and probably what is the worst, increased risk of mortality. And it's really understandable. If somebody is depressed, of course, we can ask, but we cannot expect to get good response to treatment. We cannot expect good adherence to our prescription. We cannot expect lifestyle modification, and so on. So that's why the impact of depression on the course of diabetes is really very negative. Also, it was found that incident diabetic complications have also been found to be risk factor for subsequent development of the depressive episode. If we are talking about risk factor for depression in patients with diabetes, we can divide those risk factor to two, let's say, major groups: non-diabetes specific risk factor and diabetes specific risk factor. Non-diabetes specific risk factors are gender. Females are more predisposed to depressive episodes compared to males. The lack of social support, low social economic status, younger age or older age, and physical health problems, and occurrence of critical life events. So actually those risk factors are really non-specific, and they can trigger depressive episode in anybody with or without diabetes. But also there are some diabetes-specific risk factors, like manifestation of diabetes itself. We all know how stressful for patients is to be diagnosed with diabetes. You know, this morning patient considers him or herself healthy, and this afternoon we prescribe insulin, or prescribe medication, or we change lifestyle, and so on. Of course, it's very depressive. The development and occurrence of late complications is also very important diabetes-specific risk factor for development of depression. Persistent poor metaglycemic control, need for insulin therapy in type 2 diabetes, it's also very important factor to trigger the development of depression. And once again, it's understandable. We all clinicians, we all know how difficult it is to persuade patients with type 2 diabetes to agree on, to accept insulin therapy, and of course it's very stressful period in patient's life. And persistent hypoglycemia problems are really also very important risk factor for the development of depression in patients with diabetes. Also, it was shown, by a group of Andrew Bolton a few years ago, that it was a close association between the risk of diabetic neuropathy and depression, and it was shown in a quite large longitudinal study which enrolled more than 300 patients with type 2 diabetes and diabetic neuropathy, and those patients were followed up for 9 and 18 months, and it was shown that neuropathy was a significant independent risk factor for the development of depressive symptoms. And if we'd like to be more precise, we can say the underlying factors were pain, which was caused by neuropathy, of course, and unsteadiness, another sign of neuropathy. And those two factors led to perception of diminished self-esteem and inability to perform social roles. Quite recently, it was another publication which analyzed the data from 13 samples and which enrolled altogether approximately 4,000 people with diabetes mellitus, and it was found again the association between depression and neuropathy in type 2 diabetic patients was again confirmed and again was shown in this study. And the results were confirmed, and there was no, let's say, publication bias. Also, another link between depression and the risk of kidney disease was published quite recently in Diabetes Care, in the paper on Diabetes Care, and the author said that it was sort of cycle in which having chronic disease and depression leads to hormonal changes which worsen the diabetes and interfere with people being active in maintaining the diet and lifestyle. So it's really cycle which, you know, each consequent event drives the development of other risk factor for the worsening of glycemic control and for the development of depression. We all know the ACCORD study. It was mentioned, you know, I'm sure it was mentioned yesterday, I'm sure it's mentioned today, but it was another part of ACCORD trial which we mention much less frequently. It's so-called ACCORD MIND trial. It's a subgroup analysis of ACCORD trial, but it's also a very important trial because it enrolled around 3,000 participants with type 2 diabetes, and it was found in this analysis that in patients with type 2 diabetes, depression was associated with greater cognitive decline in all domains, across all treatment arms, and in all participant subgroup assessed. So it's very important to stress out, I believe, that depression is associated also with cognitive decline. So if somebody, actually with or without diabetes, especially with diabetes, if somebody has depression, we cannot expect cognitive functioning be very well and very good. And also it's very important for our treatment of these patients, because it's my personal, let's say, feeling, my personal experience, but I believe we can generalize this to clinical practice, that in many cases we ask our patients very difficult task, and we don't actually estimate the cognitive functioning of our patients, because we ask our patients to measure blood glucose level, to adjust insulin dose, and so on. And if patients cannot even memorize our task, what can we expect, from our even very good, even very modern, even very efficient recommendations? So depression leads to decrease of cognitive functioning, and it's very close association. It's another question, actually, if somebody has already cognitive decline or even dementia, will it be depression also in such patients? And the answer is probably no, because if cognitive decline is very pronounced, or if dementia already develops, so in this case probably depression is not an issue anymore. But if patients with diabetes are depressed, so in this case we have to keep in mind that cognitive function is also affected, and affected quite significantly. As I mentioned, depression is a risk factor for development of type 2 diabetes, and there are some reason for this association, because in subject with depression there is increased activity of hypothalamic pituitary adrenal axis, it's increased activity of sympathetic nervous system, and of course we have to remember about so-called behavioral factors like physical inactivity, because we all know that if somebody is really depressed, usually this man or woman, they don't exercise, they're not active, they eat a lot, and so on. So of course, there are a lot of behavioral factors which can trigger development of type 2 diabetes. And also another very interesting association was published a few years ago, and it was shown in the analysis of 3 very large cohort of subjects. You see around 30,000 men from health professional follow-up study in the United States, around 6,000 women, and around 77,000 women from nurse health study too. And those subjects were followed up for a few years, and it was found there is strong, significant association between antidepressant medication and increased risk of diabetes. And this association was found in all cohorts in age-adjusted models. The question is whether antidepressants themselves worsen glycemic control, or worsen sensitivity to insulin or secretion of insulin, or maybe the use of antidepressant is just marker for depression, and in this case we can see just another confirmation of the association between diabetes and depression. But of course we cannot exclude the let's say diabetogenic role of medications themselves, and probably it needs to be further investigated. What are the symptoms of depression in patients with diabetes? The symptoms actually are quite wide, let's say so. Many symptoms like feeling sad, having depressed mood, inability to sleep, early waking, lack of interest of enjoyment, especially loss of interest of enjoyment in those events or facts which previously brought some sort of enjoyment, tiredness and lack of energy, loss of appetite, feeling of guilt, worthlessness, recurrent thought about death and suicide thoughts. Actually, you can see that those symptoms are quite non-specific, and probably everybody in some periods of their life can experience such symptoms of such thoughts or something like that. But it's very important, let's say, to analyze the length of the symptoms. If the symptoms, let's say, come and go, so it's not so important and so dangerous. But if the symptom stays and especially if somebody has recurrent thought about death and suicide. So in this case, we have to be very, very cautious, because it's really some sort of medical emergency. Because unfortunately, these patients can really commit suicide, and of course it will be, it will be tragic for patients and for everybody around these patients. If we are talking about the course of depression in patients with diabetes compared to this course in patients without diabetes, we have to notice that recurrence of depressive episodes is more common, the duration of depressive episodes is longer, the risk of complication, in this case I'm talking about depression, is higher, and those patients are more treatment resistant, and all of these factors lead to higher mortality rate in the patients with depression and diabetes. And of course, all those factors contribute to higher cost of this association, to higher cost of disability and treatment. If we look on I mentioned this already, let me repeat it a little bit. If we look at the influence of depression on the course of diabetes, once again, those patients usually practice poor self-care, they don't adhere to diet, they don't perform exercise, they don't use a prescribed regimen of anti-hyperglycemic medication as good as we like them to do so, and again it results in worse glycemic control, higher HbA1c level, and of course the development of complication. And here in the slides you can see the data from the study that self-care behavior is really reduced in diabetic patients with higher depressive symptoms, regardless of what kind of treatment we prescribe to them. Either it's diet or diet type or exercise, anyway, self-care behavior is really reduced. But if we are able to treat these patients for depression, it not just improves the symptoms of depression, it also improves glycemic control. As you can see, the results of this study, the treatment group in blue column performs much better in terms of glycemic control and HbA1c level compared to those patients who were not treated for depression. And this treatment actually was effective, either it was medications or cognitive behavioral therapy. As I mentioned already, depression is significantly risk factor for increased mortality, and once again you can see the results of the study, and you can see the significantly increased risk from 1.3 to 2.3 approximately odds ratio, increased risk of mortality in patients with depression and diabetes. And again, in those with depression, diabetes significantly worsens survival. So once again, it's really bidirectional association. So I can summarize that nearly a third of persons with diabetes suffer from clinically relevant depressive disorders. Let me stress once again, we are talking about clinically relevant phenomenon. We are talking about situation which we have to address in everyday, in routine clinical practice. And once again, for instance, in my practice, in my country, we don't do so. That's why we consider this as a new complication, but actually, as I try to persuade you, it's not new at all. Persons with depressive disorders are twice as likely as the rest of the population to also suffer from diabetes. And the prognosis for both diabetes and depression in terms of severity of disease, complications, treatment resistance, and mortality is much worse for either disease, again for diabetes and depression, but when they coincide than when they occur separately. How can we screen subjects for depression? There are some tools, there are some questionnaires and so on, which can be used. For instance, the last two lines, like PHQ-9 and WHO-5, those questionnaires are quite easy to use, or you can use many of them. But once again, I believe that the most important point is just remember about this association and to try to screen, or to try to refer patients to appropriate screening. But we have to use this scale. And there is some stepped care model was proposed, depending who provides care to the patients, what kind of what severity of depression we are dealing with, and whom we have to refer patient to. So the first step, of course, is at the level of general practitioner. We have to recognize this problem. The second step is a level of primary care team, primary care mental health worker, who can deal with mild depression. And on step 3, step 4, step 5, we can see moderate or severe depression, we can see treatment-resistant or recurrent depression, and of course the most dangerous situation is where we face risk to life, again recurrent suicide thoughts and severe self-neglect. And of course in this case, these patients has to be treated probably in an inpatient setting, and so the so-called crisis teams. And so again, let me refer to American Diabetes Association guidelines. Actually, the most recent, the new one probably will appear just in a few weeks. But so far, let's refer to guidelines which were published in the beginning of this year. So talking about depression, American Diabetes Association requires to consider annual screening with age-appropriate depression screening measures, and especially at the beginning of diabetic complications, or when there are significant changes in medical status, again, there is a requirement to consider the assessment for depression, because we were talking about diabetes-specific risk factor, so we have to keep in mind that any significant change in the status of patient can trigger the development of depression. And referrals for treatment of depression should be made to a mental health provider with experience using evidence-based treatment approach. Actually, it's a very difficult question, because once again, as I mentioned in the beginning of my talk, we are talking about millions of patients with diabetes, millions of patients with depressions, and probably huge number of patients who have both depression and diabetes. So that's why we are not able to refer all of them to mental care provider. It's not just realistic, it's not just possible, but still we have to refer some of them to the specialized psychiatric help. When should we do so? When we see 2 or more comorbid psychiatric disorders, once again, when we see suicidal thoughts or psychotic symptoms, when we can see bipolar depression, or if we try to provide some sort of treatment for depression for these patients, but we fail, and especially if we fail for quite long treatment, like more than one and a half months, in this case, we have to insist on referral, and we have to send those patients for specific help, because once again, it's not just matter of better or worse mood. It's matter, in many cases, of survival of these patients, because we are talking about, once again, we're talking about the risk of development of diabetic complications, and we are talking about possibility for patients to commit suicides. So both situations are really terrible and very risky for patients with diabetes. So, ladies and gentlemen, Mr. Chairman, let me conclude that diabetes and depression are really closely associated disorders. Diabetes and depression aggravate the risk of development and the course of each other's. And this comorbidity requires the joint efforts of diabetologists and probably general practitioners, let's say, from diabetes side, and psychiatrists from psychiatry side. And once again, I hope that I was able to persuade you that it's really not new association and it's not new chronic disease. And finally, let me thank you for your attention, and let me present my own tool to fight my own depression. And actually it's evidence-based, because doctors really help very much in this regard. Thank you very much.
Thank you very much for you, Professor Mankovsky, and for all the speakers. I'd like to invite all the speakers of this session to open the floor for discussions. Any questions, please?
A newly discovered diabetic in adolescence, if come to your clinic for the first time, presented as an obese adolescent, negative family history for diabetes, glycemic profile moderate, non-ketotic. Before decision which type of therapy, whether insulin or oral antidiabetic, we have to diagnose which type 1, 2, or MODI. Putting in consideration if you give insulin, it works for the 3. But we deprive him if he is type 2 from oral therapy. What measures you do in your clinic for the first time?
Thank you for your comment or case presentation, I should say. Of course, my opinion is that we need to think about safety of our adolescent patients first. So as insulin is the most safe agent for them, so we need to start treatment with insulin, regardless to, of course, blood glucose level. But during this initiation of treatment, we also can measure some autoantibodies, as we discussed yesterday during the workshop. So it will be possible way to know, is it really type 1 diabetes, or maybe it's not. So my answer is insulin therapy at the beginning. Of course, sometimes even autoantibodies don't give us the clear understanding of type of diabetes. So we are clinicians and the medicine is an art. So we need to do something with that, yes.
يا جماعة بعد إذنكم بس الأسئلة من هنا. From this side, please.
I don't really think that measurement of C-peptide is useful for such sort of patients because it's like just the level of insulin production. We don't use it in Russia. It's in my city, in my hospital, it's free for patient to use GAD autoantibodies or anti-isolate autoantibodies, insulin autoantibodies, but that's all. Other autoantibodies patients need to pay, so it's not oftenly used. That's the answer.
Yes. معلش يا جماعة بعد إذنكم السؤال يبقى واضح والاتجاه ناحيتنا مش منك للسبيكر. وسؤال واضح بليز بنغمة واضحة. اوكي؟ وسؤال مش كومنت.
I asked you before about the communication, body language and expression when assessing the patient and giving him advices and the issue.
Okay, Mrs. Speaker, can you come and?
Thank you for this comment. Oh, no, I should stay here, sorry. Of course, the psychological issues are very important, especially in teenagers with diabetes. And of course, something like language of body and other psychological motivational interview or art of listening to our patients are also very important. And of course, we need to remember about it. I don't really realize what was the question about. I just want to mention that it's very important. Yes, we need to use it.
You have a certain code in your certain code that
Certain course?
You have a system that you put a code.
Honestly, we don't have any course or any guidelines or any book about it. We are just trying to organize now a course with the name of communication skills for doctors, but we are only in the beginning, and because I think it's very important for our doctors.
مين تاني يا جماعة حب يسأل؟ We have time for one question and then coffee break.
My question. My question is for Dr. Boris. Is there a clear pathogenesis for the rule of tight or aggressive? Of tight or control in depression in our case.
So may I ask you to repeat the question? Is there any link?
If there a pathogenesis for the role of tight diabetic control or aggressive diabetic control in prevention of depression or dementia, as in case of vascular dementia?
I am afraid the answer is no. Of course, if we deal with diabetes, it's all the question. If we bring diabetes under control, will we achieve this and that and so on? But I don't think there is, I don't think there is some pathogenetic reasons to believe that if we bring diabetes under control, if we achieve normal glycemia, we can prevent depression. But on the other hand, if we exclude the swings of glycemia, if we exclude or at least minimize the episode of hypoglycemic episode, and so in this case we can expect improvement of patients' well-being, and we can, let's say, at least we can eliminate some of diabetes-related risk factor. But generally, I don't think that for now we have evidence-based data that strict glycemic control is able to prevent cognitive decline, is able to prevent dementia, or is able to fully prevent depression.
And there's no difference between tight or aggressive control and conventional treatment. There's no difference between them in
Actually, in a CORD-MIND trial, I just showed the results regarding the association between cognitive decline and depression. But the idea of a CORD-MIND trial was to address issue whether it's possible to prevent cognitive decline. That's why it's called a CORD-MIND. It just was out of the scope of my presentation this morning. But the results for this, let's say, trial were negative. Sorry.
Professor Mankovsky, another question about the effect of interactive sessions of small groups of inhomogeneous type 1 and type 2 patients, their effects on relief of diabetes distress and depression. Are there any data about such a way of interactive small discussion sessions between type 1 and type 2, which are sometimes inhomogeneous groups?
Yeah, I agree that this group is really inhomogeneous. I'm not aware of this data. It's a very interesting topic. Actually, we usually try to separate those patients because really they're very different. But on the other hand, you're right. Maybe if they cooperate and meet each other, maybe it could be helpful. But I'm not aware of the data regarding this topic.
And regards to the antidepressant medications, some of the selective serotonin uptake inhibitors increase appetite and increase food intake, and they bring the patients, of course, out of the glycemic control. What's your comment about fluoxetine, for example, using fluoxetine in treating depressed people with diabetes?
Well, of course, it's a side effect of medication, but I believe that in this case we have to compromise, and we have to prescribe those medications because it's always in medicine. We have to balance risk and benefits, and in this case, the benefits of treating of depression is much, I believe, more than the risk of worsening of glycemic control. And we are always able, let's say, to enhance our anti-diabetic treatment and to bring diabetes under control again. But we have to help our patients to fight our depression.
We'd like to thank the speakers for their elegant talk. All discussions will be put in the workshop after a break for 15 minutes, please. 15 دقيقة هنتقسم 3 مجاميع والأسئلة كلها لنفس السبيكرز موجودين. شكرا.